All right. In the interest of time, we'll get started now. Welcome, everybody. Good afternoon. This is the Advance-CTR Machine Learning for Health seminar series. It's also today being co-done with the Biomedical Informatics series from the Center for Biomedical Informatics at Brown, focused on topics related to health data science, biomedical informatics, and everything in between. Today, so my name is Neil Sarkar. I'm from the Center for Biomedical Informatics. I'm also the president and CEO of the Rhode Island Quality Institute, which runs our state's health information exchange, which we'll be hearing a little bit more about today. It gives me a great pleasure today to introduce you to Katie Brown, who is a doctoral student with us here at the Center for Biomedical Informatics. She is a registered nurse, holds a Master's of Science degree in nursing in child health and public health. And she does many things, as you'll be learning today, regards to looking at data, particularly data from large sources, and looking at how they can be used for supporting, identifying potentially interesting questions or findings that may be embedded within those data. And so with that, I'm going to hand it over to Katie.
Thank you, Dr. Sarkar. Welcome, everyone. Yeah, as Dr. Sarkar mentioned, I'll be talking today about a study we did last year, and that was also a part of a conference for the American Medical Informatics Association in November. And those conference proceedings have not yet been published, but I'll be kind of talking about that study. But I'll first actually be doing an overview of unsupervised learning, and so that's kind of the first part, and then I'll get into what I'm calling like the case study, which is using a type of unsupervised learning for clustering and studying COVID-19 and mental health outcomes. So just as a brief overview for those who are not in the machine learning space, although I know a lot of you are, but as a brief overview, supervised learning, which was talked about last week actually, is a machine learning approach that's defined by using labeled data sets. And so as you can see here, there's these labels of different shapes. These data sets are designed to train or supervise the algorithms into classifying data or predicting outcomes accurately. And so a lot of them, classification and regression are the classic examples of supervised learning. On the other hand, unsupervised learning uses unlabeled data sets. So it takes that outcome label out or doesn't have it in general. And that's what we'll be focusing on today. As the name suggests, it's a machine learning technique where models are not supervised. Instead, they are trying to find hidden patterns and insights from the data that's being input. And the formal definition, I guess, is that it's a type of machine learning in which models are trained using these unlabeled data and are allowed to act on that data without any supervision, which the name suggests. And as you can see here, this is a clustering example of unlabeled data that clusters based off different patterns it sees in the data, determined on the algorithm that is used. So just as like a fun example of what it can be, what unsupervised learning is like compared to a lot of times is the learning that takes place in the human brain. So we're constantly learning new things. My small toddler loves to try to name all the different animals. And so, he's constantly learning and constantly understanding with his little growing brain, the different patterns he sees in different animals, and he names those different animals. And then he even goes a step further and determines the differences between types of dogs. And so that's kind of what's going on with unsupervised learning, is a constant learning without having different labels. And the goal is to find the underlying structure of that data set and hopefully find similarities that represent the data itself. So just a little bit more in depth about the algorithms that unsupervised learning uses. Here we have again, kind of the animal example. You take an unlabeled input of data. So all these different types of animals you see here, in this case, as you can probably see right off the bat, we have different types of cats and dogs. And this unlabeled data is fed into a machine learning model in order to train it. And firstly, it'll interpret the raw data and then find the hidden patterns within that data using an algorithms. There are many different ones for clustering and also associations and things like that, and depending on the algorithm you use. And then once it applies a suitable algorithm based on the data set that you give it, it divides the objects into groups, classically, clusters, according to similarities and differences between the objects itself. So in this case, you would hope that it would the output data would categorize, the different dogs and cats based off of the input data. Unsupervised learning kind of has two main categories, associations and clustering. I will talk a little bit about both, but the case study today focuses on the clustering side of things. I've also used association rule mining in the past, so I'll briefly talk about that as well. And the main difference is that associations take in different input data, and the output data is something that's associated with the input data, whereas clustering really more clusters similar objects together. So, milk and bread, and the output being cheese, those aren't really all similar, but they are more associated together, like if you were shopping. Whereas the clustering, it would cluster different, in this case, different types of fruits or vegetables in different clusters. So just a little bit about association rule mining. It's an unsupervised learning method, which is used for finding relationships between variables in large data sets, and it determines a set of items that occur together in the data set frequently. It's a very classic method, decades old, and of finding different associations in an unlabeled data set. And the classic example is the market basket example analysis, where association rules help uncover relationships purchased together at the grocery store. And so in this, you can see that items bought together in a grocery store, you have a list of them. So in here, apples, bread, meats, diapers, that type of thing. And these associations, you'll have different transactions. So what are people purchasing together? And then these are the item sets that end up coming out, and you can interpret the data. And in this case, the classic example is that they determine diapers and beer were commonly or frequently bought together. And so that helps with marketing and how grocery stores will lay out their store. And there's a lot of health examples as well, but this is just the classic example. Now to clustering, there's a lot of different clustering techniques out there. Here I list some of the most commonly used ones, I would say. There's density-based, centroid-based, and all these fall under these different categories, Kmeans being one of the most common examples. And then, it's things like DB scan. And today, actually, I'll be talking mostly about self-organizing maps. So just a little bit about this one of more simpler and popular unsupervised machine learning algorithms, which is Kmeans. It's an algorithm in data mining that starts with a first group of randomly selected centroids. So we have a centroid here, and then it performs an iterative or repetitive process and calculates the optimal position of those centroids. So it finds hopefully the center, and then the output would be it would create cluster boundaries determined on how many you choose, and it halts after those optimized clusters are achieved. This only usually works best with continuous numeric data and not typically great for categorical data. And also it's usually best with smaller data sets. So I'll kind of talk about kind of the limitations on this one. It's used a lot of times, but in my case, it's not a great method to use based on using things like categorical clinical data. So here's a few more, and these are the ones that I actually will talk about in the case study. And I'll just briefly go over each of these. Hierarchical is also a very common one used, especially in the clinical realm, and it's a bottom-up unsupervised learning approach that uses subgroups based off of the presence of different input data. And then it creates the algorithm is again iterative, and those that are closest together end up merging into these different trees. And then the resulting dendrogram that you can see here is cut for the optimal number of clusters. And it's fairly subjective, but you can use different methods to determine the optimal number of clusters. And so in this case, on this very simple example, there are two clusters here, the green and the blue. But that's kind of how hierarchical works. K-modes is a categorical variation of Kmeans that looks for the mode instead of the mean of those centroids. And this modification helps with some of the categorical nature of data sets, like in my case. It again wasn't the best method for the data set that I was using, but it's a good option if you have categorical data. The last one here is called a self-organizing map. It was proposed by Kohonen and is an unsupervised artificial neural network that converts and visualizes high dimensional data onto a lower dimensional map. So it's great for high dimensional data, which was what happened in my case. So I'll talk a little bit about why why we chose the method that we chose when I go over the case study, but I wanted to give a brief overview of the methods here. So a little bit more about self-organizing maps, since that's the method I'll be focusing on today. Like I said, it's an artificial neural network that converts and visualizes the high dimensional input onto a lower dimensional map. As you can see, so you see the input vector. It has a weight matrix, as the algorithm is iterative, and then produces this lower dimensional map that you can visualize. So the input is connected to a chosen size node lattice, where the data set is distributed randomly across those nodes. And then the self-organizing map process begins with initializing the grid of these lattices with a random sample of the data set. These distances are then iteratively compared to each other. And it ends with the most similar, hopefully the most similar nodes being closest together, as seen kind of with the colors in this figure. The similar nodes kind of go to each different color, and they're kind of replaced over and over again until the ideal end map is achieved. So in my case, we used a 2-level self-organizing clustering approach, self-organizing map clustering approach, and it was used. I'll go into more details about the actual case study itself, but it was used to group different conditions together based on a patient level data set or matrix that was initialized. So the first step was to initialize, or to have a binary matrix of all the different, depending on your data set, in this case, patients and different conditions. And then you initialize a chosen lattice, and the first step puts those, you have a set number of observations per neuron. The literature states that about 5 per neuron is a good bet, and so that's kind of what we did. And so in our case, based off of the data set, you have like a pretty large lattice because it's a large data set, and you want a certain amount. You kind of want an evenly distributed data set, so that way in the end you can kind of visualize what those clusters, or what we call proto-clusters, look like. So the self-organizing map algorithm is achieved in the first step, and then, but that just gives you this map. As you can see here, it's, you don't really know where the boundaries for these clusters are. And 60 clusters, if you had, like in our case, we had 60 proto-clusters for a large data set, is not enough, is way too many to analyze individually. And so we had to go a step further and then cluster those individual proto-clusters into larger clusters, which was the second step. And then you can use them any type of clustering method. A lot of times these classical ones like Kmeans and Hierarchical are used. And then you can create boundaries on those proto-clusters to have a set number of larger clusters that you can then visualize and analyze. So that was just a brief overview of unsupervised learning. And I wanted to kind of touch on just the different methods that are out there and that are being used. In our case, we use self-organizing map, which is a pretty common technique used, but it's not as common in the health world. And so I wanted to go into more detail on that one, since that's one that we used in our study. But just a little bit about the advantages and disadvantage of unsupervised learning, which I know probably a lot of you know, but we'll start with the advantages. For unsupervised learning, a lot of times you don't have labels, and even if you have labels, you may want to have a better understanding of the structure of the data before you kind of go into more of the supervised learning techniques. And so that's a lot of times why I've used unsupervised learning, is to find patterns and maybe possibly provide new insights about the topic by doing this more. Sometimes it's more of an exploratory approach, and that's kind of where the disadvantages come in. There's challenges to validating this work because just due to the exploratory nature, there are ways of validating, but a lot of times it's fairly subjective. You have a lot of clinical experts that come in and validate a lot of times, and there are different other ways and methods to validate from a computational perspective, but it is quite a challenge. And so that's, I guess, one of the main challenges of unsupervised learning. And it could also be less accurate because you don't have that input data labeled. And so, you might not have the exact outcome or output that you expect. But one thing that's kind of cool about the self-organizing maps is that it can be used for classification as well. So once you generate your algorithm or generate your final output map, you could then use it for classification. So you could generate a new data set, let's say. So we're using this color example that you've seen in previous slides of it kind of clusters based off of these different colors that you see. And here we have a green color and a blue color that's fed and put onto this the self-organizing map. And then, you have your numbered cluster boundaries here that are already predetermined. And then you determine if it's accurate in identifying which cluster these belong to. And so if that's the case, then that could be one way of validating, and also just be a way of using this in a classification case. So I wanted to mention that as well as kind of using clustering in a kind of a more supervised way. So now to move on and talk about the case study. This paper was presented at the AMIA 2022 annual symposium. So I'll just be kind of just going over how I presented this at the conference. And so if there's any questions at the end, definitely let me know. Like I said, unfortunately, we don't have a link for the study quite yet, but we can definitely provide that once we have it if you're interested. So this, and I'll tell you what the title is so you kind of have an understanding of what the study was about. This study was using a cluster analysis of post-COVID-19 mental health outcomes and associated comorbidities. So kind of characterizing the population of those diagnosed with mental health outcomes after having a positive COVID-19 diagnosis. So as we all know, COVID-19 pandemic that began in the US on March 11th of 2020, so we're coming up on 3 years now, continues to impact most of the population and was identified as a public and mental health crisis. And so still a lot of research and efforts are being done to combat that and also understand kind of the impacts that it has had on our nation and our world as a whole. Recent research suggests that up to about 13% of people who have had COVID-19 have symptoms about a month or longer after the infection. So this is the what we're calling long COVID. Long COVID appears to affect each person in different ways, which makes it really hard to study. And the symptoms and conditions vary widely systemically, as you can see here on the right side of the slide. Lung and heart conditions, neurological symptoms, which include things like brain fog and mental health issues, stomach symptoms, such as abdominal pain, and even things like joint and muscle pain, hair loss, skin rashes, and kidney problems. So the thought is that since it's an inflammatory disease, it can affect any organ, which includes the brain. And so more research is needed to understand these post-COVID effects, including mental illness. So this study focused on COVID-19 survivors diagnosed with mental health conditions, and I'll go into a little bit more detail about that. So individuals diagnosed with COVID-19 have shown an increased risk for mental health disorders, such as PTSD, depression, and others. And but few studies have used machine learning to identify clinical characteristics and patterns associated with developing mental health condition after having COVID. So this study aims to validate that there are increased mental health diagnoses seen post-COVID-19 diagnosis and identify important features and patterns of clinical characteristics observed in these individuals. So the overall goal was to confirm groupings or clusters of mental health patients within those that have had a positive COVID-19 diagnosis, as well as further characterize and describe the patient profile seen within these clusters that could possibly contribute to a higher risk for these concerns. So seen here is a general overview or workflow of the study and approach taken. We sought to group and characterize COVID-19 positive patients with mental health disorder using a statewide de-identified electronic health data set from the Rhode Island Quality Institute, or also called Current Care. And this population was characterized through aggregate statistics, and 3 clustering methods were compared to determine if clusters of individuals with mental health disorders post-COVID-19 illness could be identified and then also further characterized. So the Rhode Island Quality Institute, for those who are not familiar, operates the Rhode Island's Health Information Exchange, or called Current Care, and it is contains electronic health record data from all acute care hospitals in Rhode Island, and also many ambulatory, laboratory, and pharmaceutical data across the state. As of 2019, there were over 500,000 individuals that had opted in to share their data with Current Care, and de-identified data were provided for the time period in this study for January 2018 to December of 2021. And this data set contained lab confirmed or suspected cases of COVID-19. And these cases were demographically matched on age, group, sex, race, and ethnicity to controls who tested negative or equivocal for COVID-19 at a ratio of 1 to 2. So 1 positive to 2 negatives. The data set adopted the Observational Medical Outcomes Partnership, or the OMOP Common Data Set Model format, which is the standardized format for leveraging standard data across from this Odyssey group, as you see here on the right. So that's a little bit about the data set. For the data pre-processing, positive COVID-19 cases were identified and extracted, and then demographics such as gender, age, ethnicity were extracted as well. These condition groupings were also, and other features of interest were identified using a combination of OMOP's concept IDs, which were from ICD-9 and 10 billing codes, and then SNOMED codes from the problem list as well. And these conditions were aggregated into broader groupings. In our case, we used FEWAS categories or fee codes, in addition to CCS single level categories, depending on a couple of different things. So in addition to mental health groupings, FECO groupings of other important clinical features and conditions were extracted. Some of these included things like hypertension, cardiac related conditions, diabetes, any other co-occurring condition that could have an impact were extracted. And then the clustering actually used any and all conditions that a patient might have been diagnosed with that was available in the data set to analyze and create those clusters. Other features from the data set included smoking status and severity of disease based on 2 different things. It was either hospitalization for COVID or intubation as a proxy for ICU status. And then the Charleston Comorbidity Index scores were also calculated just to further quantify the differing levels of burden seen in these individuals, and then also specifically in the cluster in the final clusters, or what we're called subgroups, identified in the study. In the population, just as before we get into the results, so you kind of understand the different subgroups that were studied. They were characterized, and a statistical analysis was done on the selected following 6 subgroups or so. So there's the all patient set, a COVID-19 positive set, a COVID-19 positive with a mental health diagnosis present, post illness, and then COVID-19 negative mental health subset, in addition to the 2 more severe groups, which was the hospitalization and ICU subset. So here's an example of how ICD codes were grouped into categories using both the fee codes and the CCS categories that I mentioned earlier, just so you can kind of understand how these were grouped into broader categories to then be studied. And so in this case, you have PTSD or acute reaction to stress, and you have your different fee codes and CCS codes on the left-hand side, and then how that maps to all the different ICD-10 codes. And so in our case, we mapped all SNOMED codes to ICD codes and back to the source codes. And so that way we could group all of these different conditions into broader and more understandable groupings. Then these were put into a binary matrix. And so this is, again, like I said earlier in the talk, a patient level matrix. And so each row is an individual patient, and each column is their corresponding yes or no, so 1 or 0, for presence of the condition or not presence of the condition. And then just to further analysis, the CCS categories were analyzed, and the ones with prevalence less than 1%, for more ease of the algorithm calculation for the clustering, were excluded from the data. So as I mentioned before, 3 clustering methods were used in the study and compared to determine kind of the best algorithm to use, and just review different ones, as this was kind of a exploratory approach at first to see which, kind of what was the output of each of these. And pretty quickly found out that on their own, neither hierarchical or K-modes clustering resulted in any like meaningful connected clusters or groupings of mental health conditions within COVID-19 positive group. And really what that meant was like most individuals ended up in one cluster. And so it was extremely hard to analyze and what weren't really meaningful clusters. And the reason for this was probably because of the sparsity of the input vectors or the binary variables. So meaning that many individuals would have zeros for most of the CCS groupings, and not as many ones. So it was a high dimensional sparse input of the data. And so those 2 earlier methods did not perform as well. And so that's when we moved on to the self-organizing map. And since this is really what it's used for, is dimension, kind of a dimensional reduction of sorts, it did a much better job with resulting in more distinct groupings of individuals, so that that 2-step self-organizing map approach could be done. And since it was a large data set, that's why we had to do that 2-step approach, and we ended up with 6 clusters in the end instead of a 60 by 60 lattice, and 60 clusters to analyze. So like I said, that 2-level approach was taken, and the binary matrix was initialized, and then the first step was to do that 60 by 60 lattice, which was about 5 observations per neuron, and then form the protoclusters. And in the end, we used a hierarchical method to produce the best connected clusters for the final output of the 6 clusters that we found important. And so in our case, we used hierarchical as the second step. So just a little bit of overview of the aggregate statistics of the data set and the outcomes. Based on the 3-year time period from this RI-QI data set, or the Health Information Exchange data set, about 116,000 or so patients were extracted, and roughly 36,000 of those were identified as positive for COVID-19. And about 3,000 were identified with mental health conditions that appeared after a COVID-19 illness. So anyone who had a mental health condition diagnosed prior to the illness, that was regularly being followed up on in a couple of years prior, were excluded from that number. The COVID-19 positive cases were roughly about 62% female and 38% male, which is actually just reflects the known gender proportion in this HIE database. And there was a pretty evenly distributed age range represented throughout the data. So this table shows some of the mental health groupings that were of main focus in this study, and just their distribution throughout the data. So as you can see here, things like anxiety, depression, PTSD, and kind of the different numbers there. So, you have your 116,000, but 36,000 COVID-19 patients, and just the different distributions of these mental health conditions seen throughout the data. So comorbidities of interest in this study were also chosen, as I mentioned earlier. And so these are some of those that were of focus and that were showed a statistical difference in one group versus the other. So compared to the control group, COVID-19 positive group had similar prevalences in the comorbid conditions chosen for the study, but by contrast, the mental health subgroup, so post-COVID-19 mental health subgroup, had a higher prevalence compared to the negative COVID-19 individuals with a mental health condition, as you can see here. So negative plus mental illness, and then is the first column, and then post-COVID-19 mental illness is the second column, and then the p-value for chi-square test is on the right-hand side. So just pointing out a few here so it can make a little bit more sense. For those who had respiratory failure within a certain amount of time post-COVID-19, the negative plus mental illness had roughly 5.8%, and obviously much higher in the post-COVID-19 mental illness ones. But then if you look at some of the just more common comorbidities seen, more co-occurring conditions led to higher percentages in this population, and you can see those there. There was only one that was actually lower for some reason, which is smoking status, and then cancer was not a difference at all. But the rest that we were focusing on had a statistical difference between different subgroups, and this is just one subgroup comparison we're showing here. But in the paper, we compared all these different subgroups, and there was a statistical difference between that whatever subgroups that were chosen compared to the post-COVID-19 mental illness ones. And it makes sense because of, just the severity of the population. But I'll go into a little more detail about how we looked at those in the clusters once we completed the cluster analysis. So now to talk about the results of the self-organizing map clustering, which was the main reason we're all here today. Several different metrics were used to determine the number of clusters, which is another piece of unsupervised learning that can be a little tricky. And so, there's the elbow method and different types of methods to determine optimal number of clusters, but also there's some subjectivity that goes into it as well. And so, that's where some of the validation pieces come in, and why it can be kind of a challenge to determine the optimal number of clusters. In our case, 6 clusters were chosen as the optimal number of clusters based on elbow plot and visualization of the connected clusters, and feature similarity is what it came down to. So this figure shows the final output of that self-organizing map and the final 6 connected clusters for the lattice. And so you can see those labeled here and colored because it's a continuous map. So like, for instance, cluster 3 is actually seen on the bottom and the top, but that's the ones we're comparing here. And so here on the right is a plot of a heat map, which I'll be showing several more heat maps. And to orient you to what these are, blue is less prevalence of, and these are, again, patient level. Each individual protocluster, so the little circles, were at least initialized roughly with about 5 patients per neuron. And so blue means less patients in that neuron, and all the way to red, meaning a higher number of patients. And so this is a heat map of the post-COVID-19 mental health diagnoses, with the boundary being where most of them showed up. And so clusters 3, 4, and 6, if you go back to the left-hand side, are kind of where most of the post-COVID-19 mental health patients were being seen. And so those ended up being the kind of clusters of interest, is what I'm calling them. So clusters 3, 4, and 6 are what I'll go into more detail about now. So this figure shows, and I'm sorry if we didn't see that there, but so this is the right-hand side. This is the heat map that I was talking about. I think it glitched out there, but as you can see on the right-hand side, this is the heat map of all the mental health COVID-19 patients. So now to look a little bit more closely at some of these heat maps, because they're kind of interesting to visualize where different conditions are seen in each cluster. Just to orient you to this, I know they're kind of small to see, but I'll zoom in on a couple. Here at the top are the counts plot. And the reason to look at that is to make sure that the data set is fairly evenly distributed in the end. And as you can see, you know, some protoclusters have more than others, but you know, it's fairly evenly distributed throughout. And then the latter parts of this figure, so C through L, are different conditions of interest chosen and visualized on top of the heat map. The black boundaries are the cluster boundaries. And so I'll label some of those as we zoom in on that here. But again, the blue being less prevalent, red being more prevalent. You can see how some of these different diagnoses or features of interest are shown on the map. And so that is where, like, for instance, we looked at like ICU status as a proxy for IMV as a proxy for ICU status, and then different mental health disorders, and they showed up in distinct clusters, which I'll go into more detail about. Kind of zooming in a little bit on these, here are some examples where individuals with depression and suicidal ideation visualize on the final self-organizing map, and just to label all the clusters for you so you can see those. Here's the labels here, but then if for like depressive disorders, they showed up again mostly in 3, 4, and 6. And then for SI, or suicidal ideation, suicidal behavior and thoughts, that was mostly in cluster 6, which is one of the more severe clusters, which I'll kind of characterize here in a minute. And then looking at like the hospitalization and proxy for ICU status, those were also a lot of times in 3 and 6. Some were in 1, which is actually where most of the patients end up showing up. But it's interesting that a lot of those patients were also in cluster 6. So to characterize these clusters a little bit further, based on the clustering of the COVID-19 positive cases, these 6 clusters did reveal distinct patterns, and the demographic features and average Charlson Comorbidity Index can be seen here for each cluster described in the table. And I'm highlighting those clusters of interest, or the mental health clusters, what we call them, the 3, 4, and 6. And what's interesting is cluster 6 had the highest by far Charlson Comorbidity Index. Here are some radar plots for each of the 6 clusters, just to characterize them even further from the self-organizing map analysis. And each point, to orient you to these, and then I'll zoom in on each of the clusters of interest. Each point on the radar plot is a prevalence percentage inside that cluster itself. So in the individual cluster, that's the prevalence of these different features of interest within those clusters. And so some of the features chosen to characterize these were things like gender, age group, ethnicity, mental health conditions, and COVID-19 severity. And so just again, as a kind of backing up a little bit, just so you know kind of what was fed into the cluster analysis, it was solely just individual CCS groupings, so condition groupings for each patient. And that was the only input data. And so now we're trying to kind of characterize the population a bit further by looking at these clusters more closely. So the larger polygon for each of these conditions around the radar plot correlates to a higher prevalence within that cluster. And as you can see, kind of that one I was talking about earlier, cluster 6, has the largest polygon because it contained the highest incidence of individuals with mental health conditions post-COVID-19, along with some of the other features that I've talked about. And then clusters 3, 4, and 6 are highlighting here, and I'll talk a little bit more in depth about those. So cluster 3 was largely female, even though it's a higher female population in this data set in general, but it was even higher than like the normal data set, and it had the average age of about 50 or so, which was on the lower side for each cluster. And this cluster had the second largest incidence of mental illness, and it mostly included a large representation of anxiety and mood disorders or depression, things like that. Other common comorbidities seen were things like diabetes, hypertension, obesity, and asthma. And so it was a fairly young population, but with some common comorbidities seen. Cluster 4 was about 65% female, 34% male, which is actually just what I'm calling like average distribution of gender based off the data set. And again, a lower age average of about 50 or so. And this one had the third largest prevalence of mental health conditions, so not as many as clusters 3 and 6, but it was one of the two clusters that contained a little less than half of the smokers in the data set, and the highest prevalence of the CCS category or condition category within this cluster was nutritional deficiencies, which really just meant this was a fairly healthy population, not a whole lot of comorbidities, and nothing greater with a prevalence greater than about 15% or so. So this one was more mental health disorders, again, mostly being anxiety and depression, but a healthier population. Cluster 6, on the other hand, had the largest, had the highest age average and the largest number of post-COVID-19 mental health cases, and also the largest prevalence of mental health within the cluster, which was around 78% or so. Many of these were more on the severe side of COVID-19. So like I said earlier, a lot of the hospitalizations and ICU patients were seen in this cluster that had COVID-19. And like the previous two clusters, it had a large proportion of individual anxiety and depression, but also it had some of the more severe mental health conditions such as PTSD, suicidal ideation or attempt, substance use disorder, and alcohol-related disorders that showed up after COVID-19. So this cluster also continued, had a large number of smokers and also common comorbidities, which showed the high Charlson Comorbidity Index with things such as hypertension, heart disease, diabetes, renal disease, along many others. So that kind of wraps up the results of the study. And again, this was more of a characterizing post-COVID-19 mental health patients, seeing if we could identify where those were and then kind of zoom in on those and find those different subgroups. And so in discussion, little is known about kind of what mental health complexities and advancements are due to COVID-19 pandemic and long COVID in general. And so this study used EHR data from a large statewide HIE data set to characterize some of these comorbidities seen, so some of the conditions seen in these groups within a positive COVID-19 population. We did find connected clusters within the population, and patterns specific to individuals with mental health conditions were identified in 3 of those clusters. And so there are some limitations to the study, such as comprehensive patient history, just due to the nature of the retrospective data, and also due to the limited time period of the 2018 mark. So it's possible that individuals could have had a mental health condition prior to 2018 that we didn't capture, but we felt confident knowing that those who had been actively treated for a mental health condition from 2018 to up to the pandemic were included. And so a slight limitation, but something to think about for future directions. And then also, just thinking about other pandemic factors unrelated to the illness itself that could have affected mental health conditions is definitely something to think about. So future directions would be to address these in addition to expanding this work outside of the state to the entire National COVID Cohort Collaborative, or it's called N3C data set, which exists. And then other future directions could be using these features in supervised learning methods to predict important safety concerns, such as with this suicidality that we saw in the more severe cluster and kind of identified as a concern for future work. So this study, again, was more of an exploratory analysis, but the results definitely motivated need for more in-depth look at these patterns and then how these unique individuals are diagnosed with mental health conditions and following them kind of through maybe time series analysis and methods like that in the future. But the use of self-organizing maps enabled a characterization of these COVID-19 positive individuals, which was not possible with other unsupervised clustering techniques. So that was promising, especially using categorical data solely. And the results indicate that mental health conditions seen post-COVID-19 have a high morbidity burden and more severe COVID-19 complications, including things to look at such as suicidality in the future. So I wanted to just acknowledge the co-authors of that paper that that were in the AMIA 2022 annual symposium proceedings. And like I said, we could provide a link in the future if you want to look more in depth on that study. But that's pretty much all I have for today. So I'm happy to take questions about the study or anything about clustering in general or unsupervised learning. Thank you.
Thanks, Katie. If there's any questions, you can go ahead and add them in the chat or just unmute yourself and ask away. There are no questions yet. Well, while people are waiting on coming up with questions, maybe Katie, you could talk a little bit about how this might scale to other conditions. And so while you're looking at mental health, do you think that these techniques could scale to other complex conditions?
Yeah, for sure. What's great about unsupervised analysis is if you don't have, technically there are labels in this data set. So, I could determine which patients had COVID-19 or which patients had a certain type of mental health condition. But what makes unsupervised learning interesting is that you can actually try to find some more of those hidden patterns in the data and explore those if you know some of those more complex disease applications. So, you could easily do this with, I was clustering the entire population. So this actual map could actually, you could look at different conditions in general. So we didn't have to just look at mental health conditions. We could have just looked at other comorbidities or other conditions that might be of interest to someone and seeing how those ended up laying out on the different clusters of the map or doing a completely separate analysis in general. But yeah, so you could, with this map, even study different conditions and not just mental health like we had looked at in this study.
Great. I guess a follow-on question is, this is largely an exploratory hypothesis generating study. How would you see the findings be put into clinical practice?
Yeah, so I think there's a few things that could be done. Like I said, in the one thing I mentioned in the beginning of the talk is using self-organizing map as a classification example as well. So I'll start with that one. You could potentially see, you want to cluster the different type of the population that you have at hand, and determine a final clusters. And then if you could then with future patients determine which clusters they fall under, you could maybe have those classified into different clusters and then determine maybe risk based on that. And then, like I said, also you could go further and do some more supervised learning analysis to predict some of these outcomes and identify individuals who might be at higher risk for things like mental health conditions. So if someone came in with, has had COVID-19, they're showing symptoms of long COVID or maybe even not showing symptoms of long COVID that you know of, but being worked up for some of these different mental health outcomes, we can maybe determine people who are at higher risk for some of the more severe outcomes, or just who are at risk for developing a mental health condition post COVID-19.
Great. So we have a question that's asking, first acknowledging the great work, and then what of your findings most surprised you based on what you're going into the study with?
Yeah, I would say, I don't know if it's surprising to everyone else, but I found it very interesting that most of the, and validating that most of the post-COVID-19 mental health patients ended up in that cluster 6. So it was the more severe cluster, the ones who had, the higher comorbidity burden, the ones who had the more severe COVID-19 outcomes. This was taking a totally unsupervised look at it. And so that was interesting to see how a lot of those ended up being closely connected together, and why that should be kind of a focused area. And so from that, looking a little bit more closer at the suicidality was very interesting, that some of these more severe complications, resulted in that outcome, which is why I think it's really important to, have further analysis on. So that was probably the most interesting thing to me, was just the high comorbidity burden and looking at one of those interesting clusters, and then also the suicidality.
Great. So next question is methodological applicability. And so from your experience with self-organizing maps and the neural network that's associated with it, have you seen any upper or lower bounds to data set and its utility?
So are you talking about size? I think they're talking about size of the data set here, right?
Size of the data set, yeah.
So what was great about the self-organizing map is, since we did have quite a large population here, so we had, 116,000 individuals within the whole data set, and then, 36,000 positive patients, which are what were being clustered. It's, you can use this with a really large data set, which is great, because things like Kmeans don't do usually that well with a large data set. Lower bounds, I honestly really haven't had as much experience with, although I am working with a smaller data set using very similar methodologies for a pediatric population that's much smaller, and it's performing well. So for upper and lower bounds, I'm not sure the exact numbers on those, but it has worked well with this very large data set and a smaller, more in like the 3,000-4,000 range. Now, with that said, the high dimensionality of this data set is why the self-organizing map ended up working pretty well. I feel like you could also use it with less dimensionality, but in our case, since it was so sparse, that's why the self-organizing map approach ended up working the best, because it did a little bit of dimension reduction for us throughout the algorithm, instead of trying to do that beforehand, before inputting it into the algorithm.
Great. Next question is along the lines of comorbidity scores. And so can you explain more about what the Charlson Comorbidity Index score represents with regards to your study?
Yeah, that would, oops, let me go back there real fast. So this is a common calculation seen in kind of the clinical research world. It's not perfect, has a lot of limitations, which is why I didn't really use it as much as really just to kind of explaining the populations, characterizing them, not really having it as a feature or anything like that in the actual model, but it just kind of gives us a one-line understanding of like the severity of the population. These are this is calculate. There's several out there. Charlson Comorbidity Index is used pretty commonly, and it takes in certain conditions as present or not for a patient, and gives a certain score for that patient. And the higher the score, the higher they're at risk for different things, the higher just comorbidity complexity that they have. And so here, these are the average scores. So each patient got a score, and then each cluster had an average score based off of all the patients that were in that cluster. And so that's what you're seeing here. And so as you can see, cluster 6 had a lot higher score than the rest of them.
Great. And did you dig in at all? So Charlson comorbidity is built on a couple of different sort of types of comorbidities. Are the comorbidities, were they a common type? Were they spread
Hmm.
across, or did you just not look at that?
I actually did not look at that, but that would be something interesting to also consider when like further analyzing these groups, because especially since every condition was included as an input variable for the model, or for the clustering algorithm, it would be very interesting to see how, like, if we could break that down a little bit more and see what those ended up being. I would imagine it's more on the common comorbidity seen, so things like diabetes, hypertension, heart problems, things like that. It was interesting because other ones that they feed into these calculations that wasn't as important, we could see in this case, were things like cancer and some of those type of conditions. Those didn't seem to be as important when looking at the mental health, at least like comparing it to the mental health groupings.
Great. Any other questions? If not, would you mind just going to the last slide, Katie?
Oh, yeah.
And so again, thank you everybody for joining us today. Remember, there will be a survey coming that I think will be available up until tomorrow or till the end of tomorrow. And then there's details here on the next presentation that'll be in this series. Thank you, Katie, so much for that great presentation. And thank you everybody for joining us today.
Thank you.